Hello and welcome to the CalTAP CalVet Veteran Cultural Competency Training for Primary Care Providers. Brought to you by Swords to Plowshares. If you have not viewed the general veteran cultural competency training provided on the CalTAP website, we strongly encourage you to do so first, as it provides a foundation for the following material. This is not medical training. It's cultural competency training, giving you some tools that you can use when serving veteran patients. So we'll be talking about how to identify veteran patients, VA healthcare eligibility, issues associated with military service, different populations within the veteran population, and trauma-informed care. So why is it important to know that your patient is a veteran? Health issues related to military service can open up a wealth of health-related benefits and disability compensation for your patients. Certain issues only affect veterans or might present differently among veterans. And knowing these military-related issues and conditions can enable the provider to more quickly develop a mutually trusting relationship with your veteran patient. So first, how do you know if your patient is a veteran? Well, you ask them, but there are specific ways to do that. Many veterans don't self-identify as veterans or even consider themselves veterans. They may think, for example, that if you were not deployed in combat or in wartime, that you're not considered a veteran, but that is not the case. So don't ask, are you a veteran or have you served in the military? Instead, say, have you or a member of your family ever been in the armed services? Having been in the armed services is simply an experience. It's just an historical fact. So it won't get confusing for your patient to think about whether or not they're a veteran for VA eligibility purposes or other ideas and myths that are around that title. Once you know that your patient or a member of their family has been in the military, ask them if you can ask more about their experience. This will help you to discover whether or not they were exposed to different health risks. So, for example, did they have exposure to combat, sexual trauma, or any other trauma? Were they exposed to chemical or environmental exposures? Were there other risks associated with the time they were in service, such as Agent Orange for a Vietnam-era veteran, for example? Why is access important? The VA can provide primary care and specialized care, especially with some issues that occur only with veterans, things like Agent Orange, combat PTSD, and toxic exposures. They may be eligible not only for health care, but for prescriptions at a very low to no cost, and they can have coordinated specialty care and mental health care access. They also can get disability benefits. This is financial stability. In addition to the base financial benefits, depending on the severity of their condition, they may also be eligible for aid and attendance, caregiver benefits, hospice, and ultimately burial. So what is service connection? A service-connected condition is any illness or injury that occurred during the time of service. It doesn't matter if it was associated with combat. It doesn't matter if it was associated with the specific tasks or job of the veteran while they were in service. It's anything that happens during the entire period that they were in the military. Importantly, you can also do service connection for secondary conditions. So if a veteran has PTSD and they develop heart disease, you may be able to establish that those are connected, and that can increase the healthcare benefits and disability that that veteran can get. But importantly, it's not easy. Veterans are highly encouraged to seek free legal or other aid from veteran service officers. You can find one in your community, your county veteran service office to refer your patients to. VA health care. This includes primary care, mental health care, and specialty care. If you look at the literature, the care that one can receive at the VA is as good or better than in the private market. In addition, there are instances where a patient might have a particular disease or condition, but there are different layers to it because of that military service. For example, you have an older patient who has diabetes. That's not completely out of the ordinary. But did that person serve in Vietnam? If so, they may have been exposed to Agent Orange. They can be service-connected. You can also then look to see, are there other risks associated with that exposure? Similarly, with mental health care, services are specialized. There may be instances where a patient has trauma that is directly related to very specific military exposures, military sexual trauma, combat trauma. They have special experience over decades, centuries, treating these patients. That said, not all veterans are eligible for VA health care, and the majority of veterans do not use VA health care. They may use a combination of private care and VA health care. Many of them do. In California, only 28% of veterans use VA health care. Disability ratings and compensation. I mentioned this a little bit earlier, talking about service-connected conditions. There's a process. First, the veteran files a claim with the VBA, or the Veteran Benefits Administration, providing evidence of their medical claims. The claim is adjudicated, and the VBA determines whether their condition exists, the time of onset, so did it happen during service, and the severity of each health claim. And let me just say here, many veterans, particularly the younger current veterans, have many, many health claims, both physical and mental health issues. The VA then assigns a rating to each health issue to determine the level of care and the benefits that the veteran will receive. Again, I mentioned this earlier, secondary conditions. PTSD is associated with higher levels of dementia, heart disease, and other conditions. So if those manifest even decades after the initial trauma, one can add that to the service connection and gain access to more care, more benefits, in particular when you're talking about aging veterans, medical equipment, caregiver, and aid and attendance. So looking at the service-connected veterans by disability rating group, these different percentages present different access to different care. There's a 30% disability rating threshold when a veteran can get all their care at the VA. If you have a rating under that, you can only get care for the disabilities that occurred in service, so for the specific service-connected disabilities. Over the decades, it's become apparent that certain exposures in military service lead to long lists of diagnoses. Agent Orange is one of the highest profile of these issues. Exposure to Agent Orange causes diabetes, many leukemias, and a number of other health conditions. It used to be that the veteran would have to prove that they were exposed to Agent Orange and that Agent Orange led to their condition. But now that we know that there are so many issues that fall from exposure to Agent Orange, they need only show that they were in service at that time. They don't need direct proof of a specific incident, a specific exposure. At some point in your medical career, you might be asked to fill out a disability benefits questionnaire for the VA, or actually for the VBA, the Benefits Administration, which decides about eligibility. You'll be asked to document the onset, the clinical course, the state of current condition, then the rating specialist will use that to find an overall picture of the veteran's condition, whether or not they are eligible for service connection, and what the level of their disability rating will be. Here we have a short list of exposure-related health concerns. Now, think about deployment. These veterans have no choice. They end up in places and they're exposed to things that create significant risk. Agent Orange, we discussed earlier. Gulf War service, those veterans may have been exposed to radiation in the form of depleted uranium, heat and cold, the Korean War, marching through the snow. There are also special vaccines and medication which members of the service have to take or receive. They have no choice in that. And those are regulated differently than those that we provide to the civilian population. Currently, we have burn pit exposures. We really don't know what the fallout of that's going to be. We now turn to diseases associated with military service. So that you know that your patient is a veteran, you know that they've been deployed. Were they deployed to a tropical area? Could they possibly have exposure to leishmaniasis or other tropical diseases? Were they exposed to radiation? Could they have been exposed to cancer-causing agents? You can look at the VA website for long lists of all of the diseases associated with service. We've just mentioned a few here. All right, the good news. U.S. veterans have higher self-reported rates of very good or excellent health care than civilians. Most veterans are just fine and they're in very good health, and perhaps because of those habits that they employed when they were in the service, like a lot of physical activity, they've continued that healthy lifestyle. So that said, while many veterans are very healthy, there are chronic conditions and unhealthy behaviors present among a subpopulation of veterans that you might look out for. Behaviors: excessive drinking, smoking, smokeless tobacco, and other chronic diseases like arthritis, cancer, and cardiovascular disease. You will see higher rates of anxiety, depression, and mental distress than men and women who have not served. That said, many of these veterans have not sought care for their mental health issues. There have been a lot of efforts to reduce the stigma around mental health among the general public and certainly among those who have served. Many people, for example, like to refer to PTSD as PTS, post-traumatic stress, as opposed to post-traumatic stress disorder. The disorder is seen as a word that carries a lot of stigma, but it needs to be PTSD to be a diagnosis. And that's what you need to do when you diagnose a patient and then get them the treatment that they need. There are some areas where veterans do have higher rates of diagnosis than others, and diabetes is certainly one of those. This can be related not only to the exposure that we talked about with Agent Orange, but social disparities, limited access to high-quality food, and higher rates of obesity. Opioid misuse is a big problem in the country, as we all know. Veterans don't have a higher risk for opioid misuse. There were some articles and some studies a few years back about unduly high prescription rates of both opioids and benzos for these patients. The VA has actually come a long way in reducing those prescription rates and adding pain management programs so that people can deal with their pain, which for veterans might be chronic, lifelong pain, in healthier ways. The presence of PTSD is associated with greater healthcare use. Now, this may be areas where there are conditions that are secondary conditions to PTSD, like hypertension, cardiovascular disease. There are other cases where veterans who have PTSD, they've been exposed to these sorts of risks, also have musculoskeletal disorders because of the hardships of that sort of deployment, or whatever caused the trauma, which caused the PTSD, also caused a physical trauma. Traumatic brain injury and health. Traumatic brain injury has often been called the signature injury of the current conflicts. I think now there's more attention to it, but certainly other generations of veterans have been exposed to concussive force. Also, it's not just combat that can cause the kind of concussive force that causes brain injury. It can be training exercises or a car collision while someone's in service, so something you might associate with TBI in the civilian population, same risks when you're in the military. But of course, for those who have served recently in Iraq and Afghanistan, the use of IEDs, mortar attacks, and others led to higher risk of TBIs. It can be hard to tease TBI apart from PTSD. There are a lot of similar symptoms: anger, irritability, trouble sleeping, headaches, substance abuse. Also, often TBI and PTSD are co-occurring because whatever trauma caused the TBI also led to PTSD. When you're treating women veterans, and again, it's so important not to assume that the patient in your office is not a veteran because they're a woman, they have higher risks for depression, anxiety, substance abuse, unemployment, and homelessness related to traumatic brain injury. They also have very high rates of suicide. Here's a little bit of what I was talking about, the co-occurring issues. Pain, PTSD, and TBI, the polytrauma clinical triad, often occur together, and it only makes sense. There's a trauma, there's an injury, it causes pain, there's PTSD. I also want to say that usually these issues aren't because there was one instance of one traumatic event. More likely, it's a series of events. And the more events that happen, the more likely a TBI will occur when you have concussive force to the brain. The largest population of veterans in our country are older. A lot of Vietnam vets. We still have some World War II vets. And we're looking at the Gulf War era, who are getting into their mid-50s and 60s. Older veterans are predisposed for many healthcare issues, and they're the largest population of veterans. We have the Vietnam era, very large population. We have some of the World War II era who are still with us. We have Gulf War who are getting into their late 50s and 60s. Older veterans have higher levels of chronic pain than their non-veteran peers. They also are at risk for isolation, depression. The suicide rates of older veterans is higher than other veteran cohorts, and they're overrepresented among the homeless population. A lot of interesting research has been developed about the connection between PTSD, TBI, depression, and some of the conditions that we think about when we think of older individuals, dementia and Alzheimer's. Those who have PTSD are 2 times as likely to develop dementia. Then that dementia exacerbates the PTSD. So we have a group who's very, very vulnerable. We see the same thing with TBI, an increased risk of dementia, Alzheimer's disease, and with depression. I think we're going to see a lot more research coming out in the coming years about these issues, and hopefully also a big effort to provide the resources that these older veterans will need. Now we turn to the younger veterans, the post-9/11 veterans. And by the way, these veterans are not necessarily that young. These wars started in 2001. It's quite a few years ago. But you're likely to see more incidents of sinusitis, asthma, and bronchitis. Back and neck problems. They carry enormous loads of equipment, heavy armor. We also see a lot of infertility. Again, you can look at some of these studies. You can look at the VA website for more information about these conditions in your younger client population. Health considerations for women veterans. Common physical health considerations for women veterans. Physical health considerations include back trouble, arthritis, muscular alignments, digestive illnesses, gynecological and reproductive challenges, headaches, and migraines. This group is more likely to seek care outside of the VA, and they're less likely to self-disclose their veteran status. So again, it's very important when you're asking a woman if they served in the military, if they were in the military, not to ask if they're a veteran, but were you in the military? This group also has high rates of depression, very high rates of suicide, and much higher rates of completing suicide than their non-veteran peers. LGBTQ considerations. There are some higher instances of behavioral health issues among this group of veterans, also higher rates of mental distress and suicidal ideation than other veterans. This is also a group that's likely to seek care outside of the VA. They may have cultural issues and not feel comfortable in that space, association to trauma or issues that they had while they were in the service, and so they'll seek care in the broader community. Trans veterans can get all care except gender confirmation surgery through the VA. So if you have trans veterans in your patient population, you might mix care with VA care in order to get them the services that they need. There are some differences in the incidence of and the treatment of different conditions based on race. Higher levels of alcohol use among Black men and women. Very high homelessness among Black veterans. They comprise a full third of veteran homelessness, which is very much above their actual share of the veteran population. And interestingly, TBI, traumatic brain injury exposure, is higher among Black and Latinx veterans. So now you know your patient is a veteran, you know a little bit about different risk factors, different resources. Pay attention to the ways that you establish trust with the patient. There is a military-civilian divide, and there are issues where trust can be harder to establish. So speak informally, be open and honest, and always acknowledge the possibility that there'll be misunderstandings, that you aren't a veteran yourself, or if you are a veteran, you haven't experienced the exact same thing as your patient, and they're willing to address those issues and talk about them. When it comes to trauma-informed interviewing, the goal is to increase power, predictability, and control for the patient. So trauma is the complete loss of power. Military training is a lot about being a warrior, having power, being competent, being in control. So losing that can have a real impact on the veteran patient themselves and on your interactions. So describe what kind of information that you need and why you need it, what's going to happen with that information. And again, make sure that the client has an opportunity to talk about what worries them and to introduce new topics to the conversation. Here are some more ways to increase power, predictability, and control for your veteran patient. Be explicit about when you're going to talk about trauma, when you won't be, why you're talking about it. Give them opportunities to make decisions about their care plan. And when you're talking about physical symptoms, also take the time to ask about any emotional symptoms that may also come about. Exploring difficult facts is hard not just because you're talking about painful, traumatic situations, but also because of the nature of memory and also some cultural considerations when it comes to veterans. So one, memory can change over time. Your patient may actually have deficits in memory that are the result of the trauma itself, considering traumatic brain injury or the levels of trauma. So memory can come back in fits and starts. It can be based on triggers such as smell or weather or any number of things. Another issue is people will sometimes feel pressure to tell their story in certain ways, and this can unfold in specific ways around veterans. For example, if they feel that they have some responsibility for the injury that they sustained, they shouldn't have been in that position. Other people are worse off than they are. They were engaged in some collateral misconduct. Take the example of a young veteran, they're 18 years old, and they're a survivor of military sexual trauma. They were drinking at the time of the incident. The perpetrator says, "I will tell that you were drinking, and there is zero tolerance for drinking." Under the UCMJ, which is a different criminal code than all of us have to work under, zero tolerance. You are out. So that individual might feel threatened by telling that part of the story. Also, don't discount guilt. Other people are worse off. I'm just fine compared to my buddies. So how do you refer patients to the VA? Veterans do need to enroll in the VA. It is not automatic. They can fill out a Form 1010EZ that they can get at their VA. They can also do it online with My Healthy Vet. They can also get help at their local VSO, their county VSO, to help them fill out that form from people who are very familiar with the process. If you have a veteran in crisis, or if you have veterans in your office, you might want to keep a poster around with the Veterans Crisis Line. This line is available to any veteran, regardless of discharge status. They can call on their own behalf, or a friend, colleague, member of their family can call for them for any sort of crisis, including, of course, suicide risk. You can also take more steps. Get to know the VA in your community. Where is it? Where's the medical center? Where's the vet center? Where's the CBOC? A CBOC is a community-based outpatient clinic. Get to know some of the specialty care, the transition assistance coordinators, the women veteran coordinators, the military sexual trauma coordinators. It's always nice to have a warm handoff. Keep referral lists handy for your patients. These can include pain management resources, family resources, legal resources. Make sure that you know where your VSOs are. There are also a number of different alternative treatments or activities that are available to veterans, veteran yoga groups, meditation resources, equine therapy, you name it. You only have to look in your community to find out what's going on. You can come back to the CalVet website and find these resources, search for them, and have them available for your patients. Thank you for your attendance, and don't forget there are more resources on the CalVet website for you and your colleagues.